just want to say thank you very much. I feel very honored to have been asked to speak to you from Toronto, from the icy storms of Canada, about our experiences regarding choosing wisely and the recommendation of reducing daily lab testing that might be inappropriate or unnecessary. So I'll just get started. So first of all, I have no disclosures of relevance for this conversation and this presentation. And just three very simple objectives. The first would be to review effective evidence-based interventions to reduce daily labs. The second is to describe a practical example of an effective strategy to reduce daily labs, and this would be an example from the Sinai Health System. And finally, hopefully you will be able to take away from this an opportunity to apply improvement methodology to reducing daily labs in your own setting. So again, the recommendation of not or don't perform chemistry testing in the face of clinical and lab stability is a recommendation that shows up on multiple societies' lists. So, and everywhere, including Choosing Wisely in the United States, Choosing Wisely in Canada, and I believe also in Brazil. So the Society of Hospital Medicine in the US, the Canadian Society of Internal Medicine, amongst many others, have endorsed this recommendation as well, based on the abundance of literature that describes indiscriminate use of lab testing that really make very little impact and have very little to do with clinical decision making. So to think about why this problem happens, again, like Sinai Health System, you all work in academic center where you're familiar with trainees and multiple learners at postgraduate level. And there's many reasons why learners in particular are vulnerable to overtesting or inappropriate utilization. But in order to think about the reasons why unnecessary daily labs are occurring, we want to focus on a few specific drivers. And some of it might relate to knowledge or a lack of knowledge of when an appropriate blood test is indicated. It's probably not the most common reason. There's other reasons such as cultural, like this is how we're taught, or my senior resident has told me we should order daily labs because it's easy and it's available, and it's a surrogate way of assessing clinical stability in our patients. And also we hear from our residents and trainees that they get very little feedback. So I don't know if it's similar for you in Brazil, but in Canada, our residents are functioning fairly autonomously. And when I come and review patients with them in the morning around 8 o'clock in the morning, they've already ordered many different investigations, including blood tests. And in the course of a very busy day to stabilize patients and to manage patients, we often miss those teachable moments where we can take a resident aside and say, well, let's think about the reasons why we ordered the blood test that you did, and how did it change your management, or what was the rationale? And the trainees tell us in many surveys that they get very little feedback directly from their supervising attendings regarding appropriateness of blood testing. So hopefully this will change. As was mentioned earlier, there is evidence to help us. We put together a review of the evidence in the literature to understand what kind of interventions might be the most effective to reduce or even eliminate repetitive lab testing or daily labs. And, this was a work that came out of the High Value Practice Alliance. And if you guys are interested in joining, it's got a similar mandate as Choosing Wisely, and it really originated out of Johns Hopkins in the United States, and it's an association, really conglomerate of academic medical centers who work together and try to learn and share from each other, like we are now currently doing, about strategies to reduce unnecessary testing and utilization. So what we did was we looked at the literature, and we were able to bundle interventions that were studied and evaluated in reducing daily lab testing into three main areas. The first is around educational interventions. The second are grouped under audit and feedback, which is that chart that you might see there in the middle of the slide. And the final category of interventions center around what we call electronic medical record or electronic health record enabled restrictive testing. So in other words, using your CPOE or your health records to restrict unnecessary testing. And I'll get into each of these categories in more detail. So there'll be a bit of a theme here. So the first category is around education. And we know that education in of itself is not sufficient and does not achieve sustained results. There was a really great study that was based in Australia, published in 2006 in Postgrad Medical Journal, where they conducted an uncontrolled intervention looking at education of trainees. And the education included knowledge testing, like multiple choice questionnaires, providing knowledge, providing cost education. So many trainees were very unaware of how much a lab test actually cost. And they also provided some degree of performance feedback. What they found initially was that there was a reduction. So the number of tests per inpatient day, and again, most of these studies looked at the unit of number of blood testing per inpatient day as an outcome value. It went down by 1.58, but it was unsustained. So at the end, towards the end of the study, this was a 6-month pre and post, they found that the behavior or the utilization just went back up. So test education in of itself, although necessary, is really inefficient or insufficient. To talk a little bit about the idea of displaying cost, now there's a lot of data. They're a unique health system where patients may have to pay out of pocket or have additional costs in order to conduct additional lab testing. And so the patients themselves are a stakeholder and can be engaged in appropriate utilization. So this price study was a randomized control trial that was conducted throughout the University of Pennsylvania Health System. So there are several different hospitals in the University of Pennsylvania Health System that participated in this. And what they were looking to do was to display something that is shown here in that slide, where when you go onto the computer, CPOE, to order a blood test, a cost would pop up and would indicate to the provider how much each test was going to cost the patient. And the goal was to, again, before unnecessary testing, because we knew that it would impact on cost to the patient. So this was just published last year, at the end of last year. It was a really well-designed randomized control study. And the unit of randomization was actually the lab testing groups. There was many specific practical reasons why they decided to do that instead of randomizing patients. But most specifically, it was due to their CPOE system, where it was easy to go and randomize intervention and control based on the type of test you're going to order. So what they did was they looked at 60 laboratory tests, and they grouped them into 3 strata. So one would be based on order volume, and they looked at the top 25% most commonly ordered lab tests in the inpatient setting. Then strata 2 looked at the most expensive tests. So based on Medicare fee costs, they looked at the top 25% most expensive lab tests. And the final strata looked at the remaining tests that was really a combination of most frequently and very costly tests that were performed. And so they randomized half of those lab tests to either control, meaning usual care, and the other half to have a cost that was displayed to the provider at the point of physician entry, so that they were aware of the cost that was going to be incurred based on the testing that they were about to conduct. And so this is an unadjusted outcomes chart of their pre and post intervention data. And so what it's meant to show is that when you compare pre and post intervention in both the intervention group and the control group, there was no significant change. After they adjusted for length of stay, and again, length of stay can be a confounder that can affect the number of tests that are performed. After adjusting for the length of stay, there was no overall change within each group over time. And so that was essentially a large RCT that displayed a negative study looking at the specific education intervention of displaying cost of lab testing in a teaching setting. It was a bit controversial, to be honest, because there was a lot of conflicting data prior to that too, which made it inconclusive whether displaying cost data was helpful. So the next arm of interventions that we looked at in our systematic review was around audit and feedback. And this is a fairly important paper that we reference frequently by Noah Ivers here in Toronto, where he put together a Cochrane systematic review of audit and feedback interventions and how effective are audit and feedback interventions in general on healthcare outcomes. And we know from this systematic review that audit feedback, and again, if you are doing this in your setting, are most effective when you meet 5 criteria. Number 1, the outcome that you're measuring or the performance is not great, so meaning that you're performing at a low level to begin with. Number 2, the person who is responsible for providing the audit and feedback is in a position of authority. So whether they're a supervisor or at least a minimum a colleague or an expert. A third factor that makes audit and feedback effective is when it is provided repeatedly. Fourth, it must be given both verbally and in writings in order to have a sticky impact. And 5, that it includes clear target and what the receiver should be doing with that data. So all common sense things. And so what did the repetitive lab testing interventions tell us when they incorporated audit and feedback? There were many, many studies that looked at this. Most of them were single-center studies. And again, that's sort of the Achilles heel of many QI intervention evaluation studies. But having said that, most of them were associated with approximately a 10% relative reduction in daily lab testing. The methods that were employed were various. Many were just peer-to-peer data feedback. Some of the interventions focused exclusively on high users, meaning they would go in and pull lab data and figure out who were the top 10 utilizers of CBC testing or daily labs, and they would target those high users and send them data. Another strategy that was very common was customized or individualized data. And so instead of sending data to the group, for example, saying, well, the entire specifically to individual physicians. And again, that tends to be a bit more labor intensive, but can be very powerful. And finally, there was 1 or 2 studies that looked at anonymous data feedback. And again, we think that based on the Cochrane review, that it is a least likely effective strategy for providing audit and feedback for daily labs. The last bucket or category of intervention studied are what we would call EMR-enabled restrictive ordering. And in general, it ranges from about 12 to about 20 to 30% relative reduction when we looked at the studies, again, mostly single-center studies, but it did vary quite a bit. It acts a little bit like a switch in the sense that if you turn off the POE, then that's a way of cutting off, the monster at the head, so to speak, or cutting off people off at the source. Some of the interventions looked at just removing ability to order daily labs, period. Some restricted each test to be ordered no more than 24 hours, so there would be a counter that would start at the time of ordering, and that providers could not order another CBC or electrolyte within 24 hours. And you can imagine that there could be problems with that, obviously, if there was an acute deterioration in the patient and they required additional CBC for possible clinically significant bleeding, that could be problematic. In the end, what all of these category single intervention categories tell us is that they all play a role, but really we want to see them work together. And, you know, being very North American, you know, this picture is meant to tell you, as to convey the idea of, you know, what makes a burger taste good? Is it just the bun, the cheese, the bacon, the beef, or is it everything and all the different components, just like in a QI intervention, that might be necessary to achieve a desired outcome? So next we look at multiple, what we call multifaceted interventions, or interventions that employ different aspects from each of the category that we described. So not only incorporating education as a change idea, but perhaps integrating it with EMR restrictive ordering and adding audit and feedback. So there are two studies that were often quoted and that we've included in our review in the JAMA Internal Medicine paper. One was published out of UCSF, so University of California, San Francisco, and it was a 3-year study. It was quite long. What they did, and this is out of the hospitalist group there, published by Aparna Vidyarthi, and what they did was they provided education at all levels to trainees and faculty, senior leadership support, academic detailing in the idea of audit and feedback, as well as various different incentives to residents to achieve the lowest blood testing reduction. And the second study at the bottom by Atali et al. Was published in Mount Sinai Journal of Medicine, and this is a study that was conducted in Israel, and it was very similar, combined education, audit, feedback, and changes in the order set CPOE. So they both, over time, they were all done over several years and calculated to in the $1.9 to $2 million saving range in terms of reduced blood testing. So fairly impressive and really significant. So just to talk a little bit QI, because that's my job description and what I love to think about, is you have to think about leveraging the hierarchy of effectiveness. And for those of you who might not be familiar, these are different strength interventions that we use in quality improvement and that have different effects on the outcome that's desired. With the bottom interventions, the ones that are in red and pink, called warning, alerts, education, being what we call more soft, person-focused type of quality improvement interventions. And when you move up that spectrum to the green area, the green spectrum of what we call forcing functions or automation and standardization, that really takes the person out of the equation and is more effective in that way. So it's sort of like that switch that I was talking about earlier. And so when you think of the three broad categories, if you combine all of the education, audit and feedback, and CPOE restrictive ordering, it does result in more effective outcomes. And so this is the framework that we came up with for anyone who is interested in adopting this in their setting. It could, you start with a hospital or a system-wide or even department-wide initiative. You engage all the right stakeholders, such as senior leadership, all the department heads, as well as frontline clinicians, and not to forget the lab folks. So the laboratory medicine technicians and laboratory medicine specialists are your friends and ally because they have been years trying to reduce unnecessary blood testing. And then combining that with various combinations of audit feedback, education, and CPOE restrictive ordering, that results in the highest degree of success that we were able to see in the literature. First, and I'll walk you through what we did at Sinai Health System. So this is Mount Sinai. This is what it normally looks like in April, although currently it does not look like that. There is snow outside my window right now, unfortunately. But we're a fairly medium to large academic health center located in the downtown core of Toronto, which is in Ontario. We have hybrid paper and electronic health record system, and our CPOE is a Cerner system. And we have, anything varies from general medicine to women's and infants and surgical and cardiology and all the bread and butter departments. And we are a core residency training program site. So our approach, we've been interested in choosing wisely from the very beginning, and Alan Detsky, who is a strong proponent of appropriate utilization, led this Mount Sinai choosing wisely list. And the font is very small, but the third highest ranked recommendation out of our Mount Sinai Internal Medicine Service was to reduce daily labs. And so there's been strong support from the faculty, and it aligns with the corporate initiatives. And that's important to note, because for those of you who do QI work or quality improvement, you know that you're most successful when you have the attention of the senior administrators and leaders. So we had a lot of residents work throughout the years with us, and many of them conducted useful chart audits. We found that more than 2/3 of our medicine inpatients had what we called reflexive daily or routine labs ordered ×3. And we found that that was often enabled by our order set, in the sense that the order set would show up like this. This is what it looks like. And as you can see here, it says routine AM CBC daily ×3. That was the default, and more often than not, it was checked off. So we found that through chart audit, 70% of inpatients had daily CBC, electrolytes, and creatinine ordered, and only about 1/3 of those patients actually had a valid indication. And that what we called the big three, which is CBC, electrolytes, and creatinine, were almost always ordered together regardless of their indication. This is probably something that resonates with you in the audience, since I know you've all been doing some work around daily labs as well. This is very, very common pattern described across many settings. So we went and came up with our own indications. We conducted a modified Delphi methodology to poll the attendings on medicine, and we asked them to rank the clinical indications that would be appropriate and warrant daily testing of each of those big three daily labs: CBC, electrolytes, and creatinine. And so for CBC, which is your complete blood count, that includes things like bleeding, febrile neutropenia, various primary hematological syndromes. Electrolytes, again, a very short list of appropriate indications, and even shorter for daily creatinine. And at the bottom in yellow, this was made into a poster and was distributed and provided to all the learners on the clinical teaching units. And we asked them to ask themselves that three questions. Will the test affect patient care? What is the associated financial or opportunity costs? And can you add on tests to previously collected blood samples without having to phlebotomize the patient again? And this is what it looks like on Cerner, is that we embedded all of those appropriate indications. It doesn't look very pretty, but it looks a little bit different on our screen. And so it's to help guide the learner at point of care or the provider to appropriately order a test, meaning if your patient doesn't have one of these indications, you may wish to rethink whether a CBC is indicated. So what did we find originally? So we started this about 2 years ago, and we were hovering just under 2 of the big 3 blood tests per inpatient day. And again, we only looked and focused on the most frequently ordered blood tests, which was the CBC, electrolytes, and creatinine. We weren't at this time focusing on coagulation profiles or extended lights. So at this point, when we started our first change idea, we implemented order sets, and we removed the option to order daily ×3 blood work. And we saw an initial drop that was fairly precipitous. And then a few months later, we congratulated ourselves. We did great. A few months later, the behavior changed or modified itself, and the data, the numbers went back up. So we were a bit curious about that. And so one of my colleagues sent this to me in an email. She said, you took away that option, the default option of ordering daily ×3, but what happened was that the residents went in and modified the orders so that they were actually ordering daily blood work ×5. And this was clearly a patient who had no clinical indication. The patient had a fall, had a musculoskeletal injury, had no reason to have daily CBC, electrolytes, or creatinine. So workarounds happen. And so we thought, okay, maybe at this point, then we need to think more about that idea of, are the trainees being given their data and performance? So we started for each team. So we have 4 teams of learners and on the clinical teaching units, and every month they would get their data on how much blood work they're ordering, how they compare to their team, their peers, and what the target is. So the orange line is the target. We're trying to aim 1.5 tests per inpatient day or lower, and purple would indicate the how the teams are performing relative to the others, which is in the blue line. So they get this every 4 weeks now. And so after a little bit more education and audit feedback, our numbers are coming back down again. But as you can see, it's been quite a bit of a journey along the way, and we've learned a few things. What we did learn was that, culture change is actually fairly challenging. We're putting in some forced functions with the order set changes, but as we saw, people were able to work around it, and it wasn't as a tight looped closed function as we wished. We found that restrictive ordering does have some degree of effect, but it didn't change the attitude of the residents and trainees, and that's why we needed more than one change concept in order to have some sustainability of our outcomes. So again, in quality improvement, there's often this criticism that when you have a multifaceted intervention, in the sense that you implement education and there's, CPOE order set changes, and there's audit and feedback, which of those 3 parts of the intervention is the secret sauce? What's the best part? What's the most effective? And I think the point I'm trying to make here is that, in my experience, it's a complex interplay of all 3 critical pieces of the intervention. And I think if you dropped one, it would actually have less of an effect. And so it's the whole idea that, you want to take a bite of the whole burger. You don't want to just have a bite of lettuce or, a bite of cheese or a bite of hamburger. You need the whole thing in order to have the right experience and the right outcomes. So how might you take these points home and reduce daily labs in your own setting? Well, there's many ways to think about it. So while we came up, we were able to publish and share some successful interventions at reducing daily labs. I think it's really important to use improvement methodology to understand your own context. And it's not just a simple matter of, I'm going to take what was implemented at hospital A and explant it to hospital B and expect the same outcomes. As we know with quality improvement, that the culture and the context very much affects how an intervention is perceived, is delivered, and is executed, and what kind of effect it has. So it's not just about fitting a round peg or a square peg into a round hole. Another thing for you to consider, again, is to understand your scope. Do you want to reduce all blood testing and across the entire health system or hospital? Do you want to focus on a department or an area or one unit even? Do you want to focus on specific blood tests like what we did, which is just looking at CBC, electrolytes, and creatinine? I can say that if you're going to enter down the path of making a lot of changes to your ordering CPOE system, it's very time consuming and it's a lot of work. So if you're at that stage, you probably want to implement it at least hospital-wide or at minimum within a department because that amount of work is obviously a lot, and if you're going to do it, you may as well have a fairly large scope. But the idea of looking at only certain tests versus all tests, I think, is important. And because blood tests all have different indications, it might also impact on what kind of interventions you choose. For example, coagulation profiles are probably way more commonly ordered in the surgical population, and that might require a different type of intervention than, say, ordering daily calcium levels in the ICU. So again, just to go back, so these are some of the things for you to consider, hospital or health system-wide, ensuring that you engage your appropriate stakeholders and combining different elements of the intervention in order to maximize the impact. And don't forget the power of the data, having that data performance feedback and being able to track your data over time is really critical. So that's actually all I have to share for now. I'm cognizant that there's going to be some time for question and answer, and I'm happy to take that at this point.